So I'm Ann Watson. I'm one of the third-year residents here at Swedish First Hill Family Medicine. And I'm going to talk today about methamphetamine use disorder, current trends, and current treatment options. And this will be sort of the last talk before lunch. And so just hang with us and we'll get there soon. It's been a very interesting morning. So before I get started here, I want to say that I don't have any financial disclosures. There we go. All right. The objectives for today's talk. I'm going to talk about current trends in methamphetamine use in Washington State. I'm going to describe some of the complications of both short and long-term use of methamphetamine and review the current treatment strategies. So to start off, the reason that I wanted to talk about this is, like we heard from Dr. Pearson Perry this morning about the increased use of methamphetamine, throughout the West Coast. But I have a couple of patients who methamphetamine has really severely impacted their lives. And one of them is this case, John. He's a 37-year-old man. He has a history of hypertension. He has a history of polysubstance use disorder. His primary drug of choice is meth, but also uses some opiates. He has some psychiatric history with some depression, some PTSD, and some schizoaffective disorder. He's on quite a few medications. He's on Suboxone. He takes 8 milligrams a day. He's on Bupropion or Wellbutrin. He's on Buspar, Seroquel, and Geodon. And he came in to talk to me, and he's like, Dr. Watson, like, I take this Suboxone for my opiate replacement. Can I have Adderall as a methamphetamine replacement? And I said, that's a really good question, and I don't know the answer. So sort of spurred me to want to look into this. So just backing up, like what exactly is methamphetamine? And so it's an addictive stimulant that affects the central nervous system. There are lots of names for it. Some people call it blue, crystal, ice, speed, lots of other things out there. When it's mixed with opiates, it's sometimes called goofball, although also lots of different names for that. And looking at methamphetamine use in Washington State, this graph is looking at deaths per 100,000 people. And between 2008 and 2016, this shows that the death rate increased 4 times for methamphetamine use. And this is compared to cocaine, which is just another stimulant that is out there. And so that was from 1.3 to 5.1 per 100,000 people. This is another way of looking at some of that data. Between 2003 to 2004 to 2015-16, you can see how that death rate increased and changed throughout the state. And really the big takeaway is that things are getting more orange. So there's more use. Looking at some of the demographics of people who use methamphetamine in our state, in our community, 2/3 of primary methamphetamine users were men. The majority were white, although there's a large impact in Native American populations. A quarter of them were under age 30. Only 28% of them had stable housing. 32% of people had been in jail in the last 12 months. And in looking at people in King County, 20% of the people who are primary methamphetamine users were men who have sex with men. This is looking at another way of thinking about death rates among people who use methamphetamine with concomitant substances. And so basically looking at some of the data, this comes from the Alcohol and Drug Institute at University of Washington, that 48% of people who use methamphetamine use other substances or are polysubstance users, and 36% of those people reported heroin use in the last 3 months. 20% of people who were using methamphetamine had experienced a stimulant overdose in the last 3 months. 7% who were primary methamphetamine users had experienced an opiate overdose, but 40% had witnessed an opiate overdose. And so I think that, and then finally, half of the methamphetamine overdose deaths were associated with an opiate. And so I think this really emphasizes that people who use methamphetamine don't only use methamphetamine, and that obviously we have a co-occurring opiate epidemic, but it really strongly impacts people who use methamphetamine and also contributes to a lot of the deaths. So kind of the bottom line is that, like I said, half of methamphetamine overdose deaths involve an opiate. And so it's really important when we have patients who describe methamphetamine as their primary substance of use, that we should treat their underlying opiate use disorder with equal seriousness. And that primary meth users should use Suboxone, should carry naloxone. And so, like, if we can give people Narcan, if 40% of people are witnessing an opiate overdose, that it can be really life-saving to prescribe our patients who use methamphetamine Narcan. So, thinking a little bit about pharmacology, how does methamphetamine work in the brain, and what does it do? And so, basically, it increases neurotransmitters in different parts of the brain, including dopamine, norepinephrine, and serotonin. And the point of this picture is not to bring us all back to medical school and think about, how everything binds in the brain. But basically, we've shown that methamphetamine increases dopamine in both the striatal and orbitofrontal parts of the brain, and that it sort of can increase dopamine in the prefrontal cortex. And so when we think about methamphetamine as a stimulant, it's like increasing dopamine and flooding your brain with dopamine, to oversimplify it. What are the ways that we can use methamphetamine? There are a couple of options: smoking, injecting, snorting, and ingesting. And you can see the times for like how long it takes to get to your brain circulation. Among primary methamphetamine users, 62% reported that they smoke, where 31% report that they inject. Basically, all of the different modes of use have different associated risks. You imagine when people are injecting, there's sort of risks of bloodborne illnesses like HIV and hepatitis C. And there's risk of abscesses and all the things that we know to be true about injection, although there are still bloodborne viruses that can be contacted through smoking, like shared pipes, and people will often have cracked lips or burns, and so can still get bloodborne illnesses. And there's many associations, or there's you can have negative side effects from inhalation of toxic fumes as well. So basically, injecting is sort of the riskiest form of use of methamphetamine, followed by smoking, snorting, and then ingesting. So how does methamphetamine affect our body, and what does that high look like in the short-term effect? And so we kind of split it up into a couple of different forms, or a couple of different categories. First is the psychological effects. So it can cause euphoria, and it can cause increased sexuality, but it also can cause irritability, aggression, anxiety, and panic. There's lots of physical effects, which are sort of all underneath the umbrella of sympathetic nervous system activation. And so you'll see people with pupillary dilatation, you can see tachycardia, you can see tachypnea, hypertension, increased body temperature. There's increased risk of stroke and of heart attack, and sweating. And then you also will see like nausea and vomiting, increased wakefulness, so decreased sleepiness, and decreased appetite. When we think about some of the longer term effects of methamphetamine, I think that all of us have seen these pictures before. And like, I don't know, when I was like a teenager, they would have these posted in the DMV when you'd go in to get your license and stuff. But some of the long-term effects, obviously there's a association with addiction. There's increased risk of bloodborne infections, like I said, like HIV and hepatitis. People will have extreme weight loss. There is intense itching. There's formication, which I looked up means the feeling of bugs crawling under your skin, and associated with that is skin sores, and then severe dental decay. I think, interestingly, thinking about like, why does severe dental decay happen? It's associated with a couple of things. One is that people will get really dry mouth with methamphetamine use, but people will also have teeth grinding behaviors. they're like with the methamphetamine high, people will sort of have decreased dental hygiene and also increased consumption of sugary beverages and foods. There are other long-term changes. Looking at some of the long-term cognitive changes, people have increased anxiety and psychosis. There are some associations with moderate cognitive effects and neurotoxicity. And then I thought most interesting was this increased risk of Parkinson's dementia. And so there's a couple of studies that are looking at this. Mainly there's one in 2011, another one in 2015 in both Texas and in Utah. And they found that people who used methamphetamine for a long period of time sort of had they had a somewhere between 75 to 300% increase in their risk of developing Parkinson's dementia. And this graph is from, or this picture here on the right is looking at sort of a regular brain without methamphetamine or Parkinson's, and then looking at a brain of somebody who had used meth for a long period of time compared to somebody with Parkinson's disease. I think that one of the other things that we always think about in family medicine, and I just saw a patient yesterday who was pregnant and had a history of methamphetamine use disorder is what does meth mean for pregnancy? We obviously see a lot of opiate use in pregnancy and sort of know what neonatal abstinence looks like for that. But meth in pregnancy is associated with low birth weight, premature birth, postpartum hemorrhage, retained placenta, poor nutrition, sleep and inattention to prenatal care. And then looking at children who are exposed to methamphetamine during their gestation show that there's a possible increase in anxiety and impulse control in kids. So you have your patient, they come to you and they, maybe they've stopped using meth. And what does the meth withdrawal look like? And typically it's sort of broken into two big categories. The first is that there's an acute withdrawal that takes 1 to 2 days. And so, and then after that, there's a subacute withdrawal that can last anywhere between 1 to 4 weeks. And so people can have this really prolonged period of time where they are not feeling great from stopping their meth use. The acute withdrawal, or that 1 to 2 days, is kind of typically considered the crash. And people will feel really dysphoric. They'll feel super tired. They'll just be really exhausted. They'll have vivid dreams. They'll be agitated, can have cravings and increased appetite. And then that subacute withdrawal, people will either have insomnia or hypersomnia. They can have appetite changes, and then they can have significant depression and suicidal ideation that persists. And so we've sort of reviewed some of the pharmacology of methamphetamine. We reviewed some of the sort of long-term and short-term side effects of methamphetamine, and obviously some of the increasing deaths in Washington State. And so we think about what can we do about this, and what can we do to support our patients and to help them. And I think something that I have seen sort of anecdotally in my practice, but looking at the data from UW, from the Institute, from the UW and the Drug and Alcohol Institute, is that 47% of primary methamphetamine users were interested in quitting. And so there's a lot of desire for treatment for this, and there's a lot of motivation for people who feel like methamphetamine is negatively impacting their lives. And so SAMHSA supports behavioral health interventions as the primary treatment model for methamphetamine use disorder. And so there's a lot of different sort of types of behavioral intervention. And I wanted to highlight actually two main ones here: the matrix model, and then the third one, the contingency management model. And so the matrix model is basically one of the most evidence-based forms of behavioral health intervention for methamphetamine use disorder. It's a 16-week behavioral health intervention. It's basically like CBT. And so it's group CBT sessions. People have 36 sessions, and then it's paired with individual counseling. There's also family education groups. There's group social support, and then people will get urine and weekly breath alcohol testing. And it also encourages people in attending different groups like Crystal Meth Anonymous, basically. And so there's several studies that look at the matrix model between 2004 and 2018, and they all showed a positive result. They found that there was decreased risky behaviors, there was decreased days of meth use, and that the benefit and the effect lasted for up to 18 months, which was like sort of the longest study period. The second sort of most supported behavioral health intervention was contingency management, which also encourages positive behavior change by providing positive reinforcement for patients. And so that positive reinforcement can look like a couple of things. It could be like vouchers exchangeable for money or prizes. And then if people sort of like have a return to use or have an unexpected urine tox, then people would have their vouchers withheld, or maybe their vouchers would get reset to zero. Or maybe in some cases, there was some punishment by making like an unfavorable report to somebody's parole officer. And so with contingency management, there were 7 studies between 2006 and 2009, also all showing positive outcomes, and basically found that contingency management was associated with decreased positive UTOXs, which you can use as a proxy for decreased substance use. So before moving on, basically behavioral health interventions have been shown to be really, really effective for decreasing use and helping people with methamphetamine use disorder. But obviously, I wish that I could have the time and the skills to do all of those behavioral health interventions in my clinic, but it brings us to the question of like, what can we do medication wise? And unfortunately, there's none that are FDA approved, but there's a ton of research on different pharmacotherapies. And so the point of this slide is not to read all of these medicines, but to know that these are most of the ones that have been looked at, and there's a lot of randomized controlled trials that look at basically different psychoactive medications in methamphetamine use disorder. And I wanted to highlight a few, primarily Mirtazapine, Bupropion plus Naltrexone, CNS stimulants or agonist therapy, and then Buprenorphine. So Mirtazapine, how do we think that it works? Basically it's a non-adrenergic and specific serotonin antidepressant. So we think that it can increase dopamine in the brain. And like we were reviewing, that sort of is what methamphetamine does. So it theoretically seems like it should work. So the studies that look at mirtazapine use for methamphetamine use disorder, there's basically 3 main ones. One was in 2005, the N was 20, and they found that there was improvement in withdrawal symptoms. There was another in 2008, the N was 30, and they found that there was no difference in retention or withdrawal symptoms. The third was in 2011 with an N of 60, and they found that there was a reduction in use and there was a reduction in high-risk sexual behaviors. And so basically mirtazapine, I think, is something that we commonly will use in methamphetamine use disorder, or something that we will commonly prescribe for people. And the data shows that there's kind of conflicting results, that it probably helps with withdrawal symptoms in that sort of acute and subacute withdrawal period. And that there is an association with reduction in use and a reduction in some of the high-risk sexual behaviors, which is obviously a benefit, but not necessarily any data to support long-term use or maintenance therapy with mirtazapine. The second medicine I want to talk about was buprenorphine. And like many of my colleagues have talked about, it's a mu opioid receptor partial agonist. And it's I think that the studies that look at this, there are several, but first is this one in 2015 that had an N of 40, and they found that people had a decrease in their methamphetamine cravings while taking buprenorphine, but as soon as they stopped the bup, that benefit of decreased cravings immediately went away. In 2017, there was another study looking at methadone versus bup, And they found that there was reduced cravings in both groups. But this study was very limited. There was no control. there were no eutoxes in this study. And so basically, like there's very limited data about buprenorphine, but some of the early data is sort of being promising, showing that, you know, we think that it might help cravings while people are taking it. And obviously, like I was talking about earlier, that it treats the co-occurring opiate use disorder. And we know that lots of people who use methamphetamine use co-occurring opiates. And so I think that we should advocate for bup treatment in our patients with methamphetamine use. This gets back to agonist therapy. So the question that my patient John asked me, where he says, like, can't you just prescribe me Adderall? And so basically the proposed mechanism of action, like we imagine, is that it replaces methamphetamine with an alternative stimulant. Examples are things like dexamphetamine and methylphenidate, so Adderall and Ritalin. There's lots of studies about this. There's a Cochrane review in 2013 that reviewed 4 randomized trials that looked at 162 patients. And the Cochrane review basically found that there was no reduction in use of psychostimulants. There was no reduction in amphetamine use. And there was no sustained abstinence from methamphetamine use, and no improvement in treatment retention. Since that 2013 Cochrane study, there's been 4 additional studies. 3 of them were randomized trials. The one in 2013, 2015, and 2020 looked at 307 patients and looked at Adderall and Ritalin. And they found similar things, that there was basically no benefit. And then the one non-randomized trial, that 2014 study, found that there was maybe a possible reduction, but the data was like kind of inconclusive and sort of more of a wash. So basically, in conclusion, for agonist therapy, it didn't have any reduction in use. It didn't have any sustained abstinence. It possibly reduced, I didn't talk about this, but it possibly reduced the reduction of the severity of withdrawal symptoms when people are going through acute amphetamine withdrawal, but was not as great as we might have hoped. And so then, kind of fresh off the press, is this new study that just came out in 2021 that looks at bupropion and naltrexone. And so this is a group out of Texas, and I'm sorry, excuse me. And they looked at bupropion plus naltrexone. And so bupropion inhibits the reuptake of norepinephrine and dopamine, which theoretically increases dopamine in the synaptic cleft. And naltrexone is an opiate or an opioid receptor antagonist. And so these guys in Texas looked at the combination of naltrexone plus bupropion over 6 weeks. And then if people didn't respond to that for 6 weeks of therapy, they were given an additional 6 weeks of therapy. The non-responders were given an additional 6 weeks of therapy. And their primary outcome that they were looking at was reduction in methamphetamine negative urine samples. And so they found in the study that there was an 11% decrease, basically, in the treatment study versus placebo. And so this is saying that, again, that over 12 weeks, there was a reduction by 11%. And then they looked at several secondary outcomes, looking at reduction in negative eutox. They found that there was a 6% reduction. There's a 9% reduction in cravings. There's a very modest reduction of PHQ-9 score by 1 point. And then there's this sort of treatment effectiveness assessment, which is sort of a way that people can, it's a way that people can look at sort of like how, it's like a survey that looks at how effective treatment is. And they found a small decrease in that. And so the conclusion from this bupropion naltrexone study is basically that there was a small but statistically significant decrease in use. And so there was a small but statistically significant response. And so this is kind of the first medicine where we were like, maybe this will work, or even if it's not 100%, maybe it's something that is promising. So I think this all brings us back to my patient, John. So, like I said, he's a 37-year-old gentleman. He has a history of hypertension. He has polysubstance use disorder with primary methamphetamine, but also uses some opiates. And his question about, can you prescribe me Adderall? And so I actually just saw him like 2 days ago. And I was like, reviewing all of the data, I can't prescribe him Adderall, and that there's no evidence that it will help him. But looking back at his relevant medications, he's on Suboxone, which is great because he's got some co-occurring opiate use disorder. He has a prescription for naloxone at home. He's on bupropion, but he's on a lower dose than the recommended dose. I think there's some debate of like, should I stop his Suboxone, and should I put him on bupropion plus naltrexone with this small but potentially beneficial reduction? And I think that in talking with him this week, I don't think that that's something that we'll do. And I think that treating his co-occurring opiate use disorder is probably more important for preventing death. And then I think the other thing that in his case, he's sort of been in and out of counseling. And I think the most important thing that I could do for him is to try to get him connected with one of these sort of more formal contingency management programs, or the matrix model. So in summary, methamphetamine use is greatly increasing in Washington state over the last several years, with really like drastically increasing mortality rates. More than 50% of the deadly overdoses are associated with use of opiate use or with opiates. And so it's really important that we treat our patients we treat their underlying opiate disorder and consider prescribing naloxone to all of our patients who use methamphetamines. The first line treatment for methamphetamine use disorder is behavioral health. And so trying to connect people with community resources for the matrix model or contingency management. Consider mirtazapine when people are in this acute withdrawal period to try to improve some of their withdrawal symptoms. Consider using bupropion and naltrexone for patients without contraindications. And amphetamine replacement has not been shown to be effective. And we have lots of room to go on finding effective treatment strategies with medications. That is all I have, and I would love to take any questions.
Do our patients on stimulants for ADHD experience the same long-term effects of this meth?
So the question is, do our patients on stimulants for ADHD experience the same long-term effects as meth? I think that's a good question that I don't fully know the answer to. I think that I think that obviously some of the medications, the stimulants that we prescribe for ADHD it's like a safer drug supply than methamphetamine on the street. But that's a good question that I don't know the answer to.
Another challenging one. Does our stimulant use for ADHD lead to meth abuse, similar to using opiates after surgeries can promote opiate dependence?
Yes, also a good question that I do not know the answer to. I think like anecdotes. Oh, sorry, I didn't repeat the question. So the question was, does stimulant use for ADHD lead to meth abuse, similar to using opiates after surgeries promoting opiate dependence? And I didn't look at data for that in preparing for this talk, but I think that anecdotally that yes, it has. Like anecdotally looking at our patients, it seems like it has, but I haven't looked at the data.
This one is contingency management or behavioral approaches. Any evidence for those, or have you tried them or worked with people who have tried them?
Contingency management definitely has a lot of evidence that it can be effective. And the behavioral approaches, both contingency management, matrix model, and there was also evidence supporting just regular cognitive behavioral therapy and even exercise. I have worked with patients who have used some of the less formal, like not contingency management, not matrix model. And after sort of preparing for this talk, I'm hoping to get some of my patients into some of those more formal programs. But there's lots of data out there that shows that they have been effective in decreasing methamphetamine use and helping people engage in treatment.
One last question before lunch, repeat the question. Have you heard of any research on Suboxone and Bupropion as treatment for meth use, since so many folks are using both meth and opiates?
Yeah, so the question is, have I heard of any research on bupropion and Suboxone as treatment for meth use, since so many people are using both meth and opiates? And there were not any studies looking at, like, there's a couple of Cochrane reviews and a couple of sort of like systematic reviews looking at all the studies looking at meth use disorder. And there were not any specifically that looked at the combination of bupropion and Suboxone. But many looked at bupropion alone without naltrexone, and the bupropion alone without naltrexone were not shown to be effective. And then there was just those few studies looking at Suboxone, and that there was some decrease in cravings, but there has not been any studies, at least to my knowledge, about the two together. Yeah. Okay. Well, thank you so much, everyone. It is time for lunch, and so I think we're going to adjourn and then come back at 12:30.